Here to talk about the latest COVID developments is Dr. Malathi Srinivasan with Stanford Health Care. Now, Doctor, we've been talking, of course, about the mask mandates being dropped on mass transportation. This happening at the same time as we're seeing a lot of cases of this new Omicron variant. What do you think about the timeline there?
Well, I think that we are absolutely in the middle of an Omicron BA.2 surge. It's sweeping cities, it's sweeping college campuses. We saw Philadelphia reinstate the mask mandate and then drop it pretty rapidly. But because of the availability of home testing, we're not getting laboratory confirmation of infections. So we estimate right now that we're capturing about 7 to 10% of all positive cases. Now, we know that BA.2 is very, very catchy. It's about 3 to 4 times as catchy as Alpha and Delta, and is about 2 times catchy as the original Omicron from earlier this year. But we've been protected from severe illness by several factors. And the first is the high vaccination rates in California, and we know the vaccinations really, really help drop those severe infections, drop those hospitalizations. So anyone who hasn't gotten vaccinated yet, please do so. And then second, the Omicron infection is generally less severe than the Delta virus. And the severe cases are happening in people who are unvaccinated or got risk factors, the standard things we've been talking about: age, diabetes, hypertension, obesity. And because summer is coming up and we have more outdoor activities, we see people starting to do things outside and a little bit less inside. So in the Northeast, for instance, where the temperatures have been pretty low, people are doing more indoor activities. Now, one way that we can track infections on top of the standard testing, where you go in for PCR testing or you go to your doctor for the rapid antigen testing, is by tracking actually wastewater. So the CDC has a national wastewater surveillance program. I bet you didn't know that, because most people don't, that tracks community level transmission of lots of different types of infection by county. And in California, there's about 8 testing sites. And there's also a lot of other people who are doing sampling, including at Stanford, to try to see if we can track not only COVID, but also other infections too. The second way is by community volunteers. So there's groups like Outbreaks Near Me, which collects volunteer data. And all of the data is pointing to the fact that we are in the middle of an Omicron BA.2 surge. So I think it's very important that we still be very careful, because again, we don't know who around us is really immunocompromised, who has the bone marrow transplant, who has the severe heart failure, who has the advanced diabetes. These are hidden illnesses. And as we're trying to be good community citizens, it's very important that we try to keep ourselves healthy and keep our communities healthy.
Now, speaking of variants, Moderna is sort of tweaking its formula right now to try to come up with a vaccine that's more effective against some of the latest variants. What do you know about that and how effective it is?
Well, and the bivalent Moderna vaccine is probably about the same or a little bit more effective against protecting against Omicron. But the problem is that it's really hard to tell because of the way they did their initial study. Now, first, the study wasn't geared at clinical effectiveness. It was geared to see if you'd have a good immune response called immunogenicity, and they tested it a couple different ways. And second, to see how safe it was. So they also didn't do a few things that you would normally do, which is have a control group against the standard booster. So they took people, about 900 people, who'd had 2 Moderna vaccine doses, and randomized them to only 2 groups, kind of a low dose bivalent vaccine that had the spike protein to the Omicron virus, as well as the spike protein to the standard original strains, and also to a high dose, 100 micrograms bivalent vaccine. And they followed them for about a year, on average about 5 to 6 months. And they also took about 600 of these people to randomly sampling them for baseline immune response to the 2 standard doses. So they didn't add a third group of the standard low dose booster, and they didn't add a fourth group of the standard higher dose booster. What they did instead is they took data from another study of about 170 people who had received the third Moderna standard booster. And what they found is that everybody was about the same at baseline, including the people from the other study. And the side effect profile for all of the different doses they used was about the same. And, people had the standard arm pain and fatigue and headache and muscle aches. The efficacy was, which is, the clinical endpoint, they tested it secondarily and they found, between 3 to 10% of people who got the booster got COVID afterwards, but there were no hospitalizations, which is good, which is what we were seeing also with the standard boosters. The point that they made in the study, and again, this is a preprint, so it hasn't gone through peer review yet, is that the immunogenicity, which is your immune response, was about twice as high for neutralizing antibodies against Omicron at the higher dose than with the standard booster. And the 50 microgram, the lower dose bivalent, and the standard 50 microgram booster were about the same. So, how do you put this all together? Well, if it was me, I'd probably take the bivalent vaccine just because I think it's got a good safety profile and it's got a theoretical advantage. But is it really worth the time and trouble? I think it's too early to tell. I think we're going to have to wait for a little bit more data.
I love hearing what you're saying about not having hospitalizations, because that really is the
Right.
goal of a lot of these. And if you do end up with COVID, there are these antiviral treatments. What is the supply looking like? And if somebody does test positive, how do they get their hands on these things?
Yeah, the supply is looking good. It's not the same as it was a couple months ago. So getting anti-COVID drugs has become easier as the supply has increased. Now, it's still not an unlimited supply. And I want to emphasize there's really three different types of outpatient treatment. There's things for the general public, which are the three, the oral antivirals, Paxlovid, Molnupiravir, the IV antivirals, which you really need to get from your doctor at an infusion center, like remdesivir for 3 days, which only used to be inpatient, and then the monoclonal antibodies, which also you can get as an outpatient. There was a fourth one, sotrovimab, which was paused a couple months ago because it doesn't work well against the Omicron BA2. And there's also, for people who are severely immunocompromised, a monoclonal antibody they can get as an infusion. But this is really for people who've had like bone marrow transplants and who are severely immunocompromised. And usually their specialists will prescribe that for them. So there's two ways of getting outpatient treatment now for the oral antivirals or the monoclonal antibodies. And the first is something that was just released a couple months ago called Test to Treat clinics. And these are pharmacies with on-site clinics, and you can make an appointment online, or you can show your positive test from home and then reconfirm and then get a prescription. And these clinics have providers who can write those prescriptions. And the way you can find them is through Health and Human Services, the Office for the Assistant Secretary for Preparedness and Response. And I know that's kind of a big mouthful, but the website is www.aspr.hhs.gov. So if you just put in Test to Treat Clinics, Health and Human Services, that website will pop up. They also have a language line in case people aren't, as comfortable on the web. They've got disability access, and you can find which clinics are available in your area. Put in your zip code, put in the location, and you can figure that out. The second thing you can do is if you don't want to go to the Test to Treat clinics and there's no availability, on the same website, if you just type into the internet a COVID-19 public therapeutic locator, on that same Health and Human Services website, you can figure out where there is availability of all three of the different outpatient medications that are available. And it'll tell you the number of doses that each pharmacy has near you, and also which ones are close to you. So you can kind of set the parameters for how far you want to drive. And you just need a prescription from your doctor. And the website's pretty easy. Right now, I think in the country, there's somewhere around 630,000 doses of Paxlovid available. And the good thing is that the Test to Treat clinics, which are, again, you make the appointment with the pharmacy and then they can both test you and prescribe for you, that has a separate supply of the antivirals than the standard prescriptions that you would get filled at your pharmacy, because the government, as you know, is buying all of these medications in bulk and giving them to the states. So the Test to Treat clinics have a different supply chain or a different funding source than the standard prescription. So the availability is good if you get sick and you think you're getting sicker. Certainly if you've got respiratory symptoms, if your oxygenation goes down, if you're immunocompromised, if you're older, certainly over 65, certainly over 80, please consider getting some of these outpatient treatments. I will say that Paxlovid has a lot of drug-drug interactions. So about, 50% of the standard medications interact with it. So if you are going to use that, have the pharmacy or your doctor check to make sure that if you're taking a medication, it's not going to interact with this drug.
Okay, really good advice there. What about the possibility of a nasal spray to fight off COVID? We've been hearing about that. How close is that to reality?
There's two different types of nasal sprays that are being tested against COVID now, but they're all kind of in early testing phases, so it's really too early to tell. The first is nasal vaccines, and the second is post-exposure treatment. So the vaccines have a potential advantage of halting infection through a localized immune reaction called a mucosal immunity, but it's too early to tell if they're effective. Most of these nasal sprays use a carrier virus that either doesn't infect humans, like the one for kennel cough for dogs, or there's a chicken cold virus, and stud it with the spike protein, and or they might take, say, an inactivated human virus like the common cold virus called adenovirus, and again stud it with the spike protein, spray it in the nose, and see how people do. Now, part of the problem is with the high vaccination rates, it's hard to find people who've not been immunized who can test this for us. And also, most of these studies are in phase 1 or early phase 2 studies. So we don't have a lot of good data about how effective these things are, but theoretically there's an advantage, and they should be pretty safe. We do know from the nasal flu virus that the effectiveness of the nasal flu vaccination was lower than the injectable medications and the injectable vaccines. And it did have a few higher incidents of things like Bell's palsy, which is a usually reversible partial facial paralysis. The other set of treatments that are being tested, and again, just tested right now, are things that are post-exposure treatments. And these include things like some small molecules that Cornell is developing to prevent the COVID virus from fusing with the cell membranes. It's called a transmembrane serine protease inhibitor. And there's also some nasal steroid sprays based on some data from Cleveland Clinic, looking at about 70,000 people who used either steroid nasal sprays or didn't, and found that it maybe is helpful, but there's no studies about that. There's also a few things of like monoclonal antibodies for the nose, testing the spike protein, and some things that are being done with nitric oxide and xylitol. But right now it's all experimental, and there's nothing that's really definitive. But some of these things may be promising. We've also seen things that we thought were promising, like ivermectin in the past, that really didn't pan out. So I think being cautious about those and not being overly enthusiastic is important for a lot of these therapies.
All right, it is all a new frontier. Thanks for your perspective, Dr. Malathi Srinivasan with Stanford Health Care. We always appreciate it.
Thank you so much for having me, Anne. It's nice to see you.